Hi, everyone. Thank you for joining us. Our space today is hosted by myself, Ellie, co-director of Diag, Democrats for an Informed Approach to Gender, and my co-director, Eliza.
Hi, everyone. Diag is a 501c3 nonprofit organization of lifelong Democratic voters working to depoliticize and shed light on the ideologically driven medical scandal and associated harms that have resulted from the adoption of gender ideology. We're building a movement to shift the prevailing narrative around the experimental, dangerous medical practices that comprise sex trait modification, euphemistically known as gender affirming care, and to clear the path for a safer, saner, evidence-based response to gender distress. Please visit our website at di-ag.org and check out our merch store if you'd like to help us continue our work, and please hit the donate button as well. Diag believes in the liberal values of free speech and open discussion, which is part of why we host these spaces to invite conversation on topics that have been left out of the public discourse. The opinions expressed by our guests are not necessarily the opinions of our organization.
Okay, before we get started, I'm happy to announce that we just posted our first haiku, one of the entries to our haiku contest celebrating our 6-month anniversary, and we'll be posting them throughout the week and into next week. We're still accepting submissions through the 22nd, so please send yours in. We're joined today by two guests, Dr. Kristopher Kaliebe and Dr. David Atkinson, both child and adolescent psychiatrists. Dr. Kaliebe is a professor of psychiatry at University of South Florida in Tampa, Florida. He is board certified in psychiatry, child and adolescent psychiatry, and forensic psychiatry. He's also one of the creators of the Restored Childhood Gender Toolkit. Dr. Atkinson is also child and adolescent psychiatrist, and he's an assistant professor of psychiatry at UT Southwestern Medical Center. They're both also members of the American Academy of Child and Adolescent Psychiatry. As usual, we'll leave time at the end for questions from our listeners, so please hold off on requesting to speak until then. And as always, we welcome and expect respectful dialogue.
Okay, we'll just go ahead and get started with some questions. So let's talk about the origin story of the article that you co-wrote, Adolescent Onset Gender Dysphoria, Our Perspective. Chris, maybe we can start with you. I'm curious how you came to work together on this article. And I'm kind of asking because, no matter what your profession is, it's extremely challenging to find others who are gender skeptics, much less willing to speak out. So how did you find each other, and how do people in any profession who dissent on the gender affirming care model find each other?
Well, Dave and I were on the media committee at the American Academy of Child and Adolescent Psychiatry together. I was the co-chair of that committee from 2013 to 2021. But I've been I've been participating in that committee since 2004. Was the first time I presented there, and I didn't. Uh, uh, I didn't originally. I was the one who first wanted to get an article into ACAP News because I had tried to get things published in our journals and got nowhere. And I thought the newsletter might be a place, that would be willing to publish something. And Rob Grant, who's one of the ACAP staff members, I had a good relationship with, and I had started to write the article. And then I knew that Dave was a thoughtful person. I didn't know all of his, opinions on this issue, but I knew that he had a healthy skepticism about these things, and so I invited him to join me. And obviously, I believe that two brains are always better than one, and so we ended up with a much better article. Having him involved, but that was pretty much the story. I did have a staff member I had written articles for ACAP News before, and it was a place where actually it is well read among child psychiatrists, even though it's not part of our peer-reviewed journal. Things, and they had rejected something previously, so Rob Grant kind of owed me one. So I negotiated that they would be willing to publish this, and thankfully they did.
Great. That kind of leads me to the next question was, what is the climate among your colleagues when you express skepticism about the gender affirming care model? And then, and maybe you both can answer the second part, what have been the consequences or benefits of speaking openly about this?
Well, I'll just keep talking, and then I'll let Dave talk. For one, I brought this same issue up at my local branch, and it was among a big room of different child psychiatrists in my local branch of the American Academy of Child and Adolescent Psychiatry, and everyone seemed very in agreement that our professional organization is failing to provide a forum for us to discuss these issues. And no matter how people felt about it, they were very supportive of our professional organization, wanting, performing more rigorous discussion. And everyone knows, I mean, most child psychiatrists actually know that this is not good care and that we're doing a lot of bad things. Most of them are just afraid to speak in public. So I think, obviously there are many that are supportive of this. There are many that are supportive of affirmative care. I think there are a lot more that are skeptical. And all we need is a few people, because once you speak up, other people will speak up too. But in the power structure, they are the ones who really don't want to have a conversation, and with good reason, because they don't have the facts on their side. I'll let David give his take.
Okay, great.
Yeah. And one of the interesting things about this, first of all, I have to tell you, related to the question, is that I'm not officially representing UT Southwestern here. That is, I do work there, and I'm not going to hide that. But I'm not officially representing them because I don't have permission to talk about those things. They try to stay apolitical, but I don't really see this as a political issue fundamentally. I think going back to the beginning when I saw like one of the first, patients I'd seen trans patients before, but in 2014, there was a patient I saw that was reporting transgender identity. And this was somebody who didn't really look like they were entirely bought into their identity. It was tearing up the family. And I just kind of like added a dose of skepticism to the clinical care. And I found that one of the things that really did that happened right away is that you had some clinicians were extremely upset that I was questioning this because they really felt, oh, this is the cause of the kids' distress, is that they're not being affirmed in their gender. And I was thinking the family tension that we're causing is probably prohibiting the real solution here, which is kind of like resolution of family conflict. And, it was one of those things where right off the bat, 10 years ago, we had some polarization of opinions and it was a touchy issue. I remember getting a little bit of a side stare when I walked into an elevator, but this is one of the things that comes with having the responsibility of working with kids is that and having such a broad effect on their lives is that sometimes it's not about your comfort. Sometimes you have to bring these points across. And after we wrote and published this, and Chris was kind of the brains behind it, and I was a little bit of the style guy. And he, and it was with his courage and he putting this out there. I was like, we can't leave Chris hanging. This is too important not to push. And I found a lot of people were kind of quiet, who had been quiet, were very supportive, and they were kind of like, thankfully, finally, yes, somebody bringing this up. So I think we have a chunk of people that are very ideologic, that really believe this is the right thing to do, and I don't really they really believe this. And then we have a lot of people that are quite skeptical. And I think what we want to do is normalize the skepticism and set a framework for healthy dialogue about this.
Great point. Going back to something you said at the beginning, I never could have imagined that a resolution of family conflict would be a radical idea. Now that is really downgraded and the priority is focused on affirming the child's identity. Um, so you, in this article, you guys did something kind of unique. You used these disconfirmation or Socratic style questions, which is pretty uncommon in almost all circles of debate on this issue. And kind of links to what you were saying about having open dialogue and injecting skepticism. The questions were really powerful, and we have some similar suggestions on our website. For those that haven't read the article, I'll give a few examples. Do mental disorders provide identities to adolescents? Can the medicalization of adolescent identities cause iatrogenic harm? And what trade-offs happen when an adolescent's perceived gender, gender role, or gender expression is elevated to a status equal to or more important than their biological sex? I'm curious, how did you decide to use the framing of Socratic style questions to make your points? Maybe Chris, you can answer that, and then we'll go to David. Just curious about what went into the development of those questions.
Yeah, I think we were trying to bridge the gap between what people feel are sort of the acceptable bounds of discussion on the issue. And I know there's so many unknowns, and there's so many underlying philosophical paradigms, and there's so many basic clinical issues that have really valid, multiple viewpoints, that I think by using questions we start to bring people into a discussion. And I would really love to hear the answers to these questions of other people on this issue. And the people who feel differently, I would love to hear how they would answer these questions. And so I think this is a better way. Like if we can rather than sort of saying I stand for this or that in sort of a firm way. I mean, I think there's so much nuance in all of the in all these questions and the approach. So I think this is a better way forward to just ask these basic questions, and it's very congruent with how psychiatrists usually practice, because we're often asking Socratic questions to patients and letting them, say what their perspective is.
Exactly. That's a really good point. That is the role of, or what psychiatry and psychology used to look like, where you're not leading your client, you're inquiring, challenging, asking them questions, and then they find their own answers. Well, have you employed any of these questions in sort of more real life scenarios? And if so, how has that gone?
Yeah, I've asked a couple of the questions at medical conferences, and one of the things is that a lot of times the people who are very big in the gender affirming care world are going to want to avoid answering these questions. In asking an adult, I was asking an adult gender affirming clinician about adolescents, and I was talking about what he kind of objected to the term because didn't really want to answer the question. But then, I kind of rephrased and kind of answer, and you could see it's like he, did say that, a lot of caution is needed when doing gender affirming care in adolescents to make sure what's, the right, that this is the right diagnosis, make sure you're not rushing things. And that is the type of thing that the people who practice adolescent gender affirming care have been very loath to acknowledge. And I think it's something that they it just feel so pressured that they have to take this unquestioning and uncompromising, stance. And unfortunately, it's like when you don't leave any room for nuance, you don't leave any room for correction. And I feel that's with the adolescent gender affirming care clinicians, that's more of where we're at. um, yeah, and I think that is a limitation of trying to employ this with that group.
Yeah, and I
Can
think.
I
Oh, go ahead,
I
Chris.
would like to add something. Yeah. So
Yeah.
I think there's an underlying difference of vision or paradigms when people regard, gender distress. And one paradigm is a rights-based perspective, and it sort of sees this as the right of the individual to demand, the type of care that they want. And that is sort of an all or nothing because that's really a political and ideological viewpoint. And usually in adolescent and childhood, psychiatry, we are used to working in a developmental paradigm, which brings in biopsychosocial, the full range of influences, and we know to understand the person is still in the process of development. And so I think when people approach these issues, a lot of clinicians who are affirmative have never really examined what is their underlying paradigm that they're coming from. And I would contend that they come from a biological and rights-based perspective almost only, and they seek to sort of not have a discussion about all the developmental issues and complexities that are going on. And I think it'd be better for everyone if we bring out in the open, if they are talking about a rights, then that's fine. Defend what you're doing on a rights-based perspective, but I think it's reasonable and probably prudent with adolescents to really use the developmental perspective.
Yeah, absolutely. A good point. And that's really one of our follow-up questions here is a little bit more about the developmental piece. But maybe we'll go to one more question about the article specifically. You know, one of your recommendations from the article was to address slogans used to justify gender affirming care and to sort of guide adolescents toward a construction of meaning or finding a sense of purpose. And I'm curious, how can fellow psychiatrists, parents, teachers, doctors, therapists best do this when they're working with or parenting a child who really is captured by slogans and ideology? I don't expect you to have the absolute answer to this, but I'm curious your take on it.
Yeah, I think the one I object to most is, would you rather have a living son or a dead daughter, or living daughter or a dead son? That one absolutely gets me for a couple of different reasons. Is one is it's a little manipulative of the parent, manipulating them into accepting this gender transition. And I've talked to parents who've heard this line from therapists or doctors more than once, several times. The other thing is when the kid hears that, they think, the logical implication is dad's not accepting my new gender identity. Therefore, he probably wants me dead. Um, and you look at cognitions that could lead to someone actually acting on suicide, someone actually, if you suggest that people who don't affirm your identity want you dead, that's an extremely stressful place to live in. And this is, I think exactly where clinicians have to understand that they really do have a lot of power. They really have a lot of influence, and that can be pushed in the wrong direction. Um, and I think that there's many other slogans that could be addressed, but that's just one I find very glaring.
Well, I will echo, Dave's concern about that. I actually was on a trip recently and met a lady who said, wow, yeah, 4 of my peers, I know 4 of them that had, kids who have transitioned. And I said, oh, yeah, I'm kind of involved with that. And she's like, well, yeah, I guess, they would have committed suicide otherwise, you know. So, I mean, this is clearly a message that has been, used to, I would say, strong arm, parents into going along with affirming care. And I think parents are reasonably, cautious and reluctant to go along. And this has been really disgraceful that clinicians are using that. Just to mention a few, I mean, think about, you've probably all heard the born in the wrong body, like as if someone could be born in the wrong body. I mean, I think once again, this is another toxic saying. This whole that gender affirming care is a life-saving care, back to the whole suicide myth. I mean, once under that, trans rights are human rights. When you talk about this as a rights issue, it gets away from what is good, clinical practice. The trans erasure, trans genocide, all these, so any of these sort of catastrophizing phrases that are being used to make this into more of a political tribal thing than a reasoned discussion about how to handle gender distress in adolescence is undermines our ability to work with both the kid and the parents. So I think a lot of education and that those slogans have somehow become popular despite they don't have an evidence base, behind them.
Yeah, and I guess where it gets tricky is, slogans have such power. They're short, they're catchy, they get repeated over and over again. Do you have suggestions about how specifically to sort of address that in families or just in society at large?
Well, I think one thing is just acknowledging is that, even if, if you say, okay, well, gender transition might be the right thing for some people, it therefore also could be the wrong thing for some people. And it's something where, when you meet somebody who's talking about this stuff, is just understanding. I just think, expressing this, I don't know to say these things. I don't know if it's that clear, and just to tell me what you think. I feel like, kind of asking and hearing, because sometimes it's like, because I usually work with adolescents who use drugs, I do substance use, and those are people whose minds are kind of hard to change on things. And sometimes if we're too direct in the confrontation, sometimes we need to kind of ask and see if we can open that dialogue.
Yeah, I think Peter Boghossian would call that planting seeds of doubt, just asking a question and then walking away and letting it, fester a little bit.
Yeah, we all want to, and that's the thing. We all want to save face. I mean, yeah, I mean, if you've ever been in an argument and you've realized you're wrong, it's like you kind of have this little feeling in the pit of your stomach. You don't necessarily want to right then openly acknowledge it, but the next time you discuss that topic, you might address it differently. Sometimes we need to give people a little bit of space to make their change.
Yeah, one thing that you mentioned earlier, first was the idea that you know this is a political, to approach this as a political issue doesn't work, and this is, I wanted to jump in then, but I'll say it now that a lot of what we're pushing for is to depoliticize this issue, because it has destroyed the ability for people to approach it from, looking at it as, is it evidence based? Is it not? It's just become so a polarized political issue, and the ones who suffer for that are the people who are then treated, with these non-evidence interventions, because we can't have a nuanced, rational discussion about this, and obviously clinicians are part of that issue. The other thing was that these slogans that you see and the coercion with parents and with young people themselves, how destabilizing it is for a child to believe that their parents want to withhold something from them that they've been told will save their lives or is necessary for them to be happening. So, and this is part of, the, these different, even the mindset, part of child or adolescent development, this whole realm that seems to have been, it's being ignored to a certain extent. So, um, you have these widely accepted stages of child and adolescent development that tell us, about understanding the differences in biological sex and what that means. And those things happen at particular stages. Adolescence, you have, the risk-taking behavior, inability to comprehend long-term consequences. These are things that have long been accepted as part of adolescence. But somehow that's being ignored. So can you talk a little bit about the developmental vulnerabilities of adolescents that make this cohort maybe more vulnerable to these messages?
Yeah, so I would love to jump on that question because it really is disappointing for me that the mental health professionals who are involved with these youth are not taking a more developmental perspective. First off, it is the job of emerging adolescents to rebel against the society that came before them and their parents, and they have to show over time that they are developing into an independent human being and breaking away from their parents. So there's some amount of natural, normal rebellion that is going to go on with adolescents. Plus, they need affiliation. So they really are peer oriented and they're really going to work hard to figure out what's going to work, be popular, to get where do they fit in their world of peers. I really like Judith Rich Harris's group socialization theory. I think it's a great way to look at like how we become the person that we will become, and a lot of it is through the peer group. Probably less parentally oriented in terms of what we choose in life and where we go than a lot of other mental health theories. Then you have youth who have underdeveloped prefrontal cortexes and have emerging sexuality, which is confusing, frustrating, and causes all sorts of challenges and problems. All of that is going on in the context of someone who really has no life experience, especially in the modern day and age when we've really coddled our children and they're not out skinning their knee and taking risks and doing a lot of stuff that they should have been doing as they're growing up. So, right in all that, I think there's so many reasons that we were doing the sort of the opposite we would normally do in mental health, and which is trying to bring the family together, have them work together, and allow some degree of healthy rebellion, but put some borders on it so people don't do any harm to themselves.
Yeah, and and I think the thing is, it's like I'll just, to be honest, it's like going back to when I was an early adolescent. There was a lot of things I didn't like about, being male. It's like, this idea that women start to see you as a threat, females start to see you as a threat is not something I was very comfortable with. As somebody who's, kind of sensitive to that idea or whatnot. And the other thing is, it's like when I was talking to back in like 2005, and she was a natal female identifying as male, and but she was really focused on just how, the female bodily processes really disgusted her. And this is something that kind of struck me as, well, gosh, didn't you have time and puberty to get, adjust to this or whatnot? And it is a process of being male and female that come with it that are biologic and social. There's these people who are the natal females who are detransitioning. There's kind of the 3Ds, is they often find being female too disgusting, too difficult, or too dangerous in the terms of, their own vulnerability to sexual assault and whatnot, is something that's very hard for them to come to grips with. And when you talk about difficulty, there's a lot of difficulty in successfully navigating the adolescent female and male cultural hierarchies. I mean, the female cultural hierarchy is notoriously difficult at this age. And man, it could be really easy to imagine that the grass is greener on the other side, because some of that experience is brutal. Similarly, if you're a male and you don't excel at these coalitional activities like sports, or you're more of a person into one-on-one relationships, you're into, art or something, you're into more, one-on-one conversations, and then you don't really have the mindset for these, being on the football team, it's easy to feel out of place. And man, it's so easy to imagine that if I were just the other gender, these things would be easier.
And add to that, that a lot of these young people already came in with comorbid mental health issues, right? We see that and or neurocognitive challenges, autism or autism-like um, characteristics, depression, or survivors of some kind of trauma. So, we have this vulnerable population that's already uncomfortable with these things, and then we're going to add this layer that they're dealing with all these other kind of internal discomforts and pressures.
Can I add that
Yeah.
this is a population, and I don't have exactly the numbers, but so many of these youth, and especially the females, have already been placed on medications, and so they're already used to taking, psychiatric medication. So for them, taking a pill to modulate themselves is not a big leap. They've already been introduced to it. Furthermore, if they're on an SSRI, that is a medication which will affect their sexuality, which will not be coming, right. For a lot of them, they can have side effects, or and some other antipsychotics and other medicines can also alter some of these processes in ways that may have them not feeling what they would normally feel as these, the sexual awakening or the sort of sexual component of puberty is bubbling up. And so you have, as you're saying, the primary sort of neurocognitive disorder in some of the kids with the autism or ADHD diagnosis. In addition, the comfort with medications, because they've already been in a society that so quickly goes to medicate kids' problems. And then thirdly, you have side effects from the medications that can be contributing to them not feeling what a normal teenager would be feeling. And so 100%, we're mixing all this in with everything Dave said and I was saying about how hard it is to be a kid today, and how a lot of kids have, we failed to prepare them for adolescence and growing up.
But surely your fellow clinicians, your fellow psychiatrists must be aware that these factors can contribute to the distress. But something happened. I guess we have questions about this later, but obviously something's happened in the field um, about this. We'll come back to this topic.
Yeah, maybe it makes sense to go to our next question, which is loosely related. So when we had talked earlier, one of you had mentioned that family cohesion is a strong form of suicide prevention. Yet gender ideology really seeks to decrease that cohesion by pushing young people, into the arms of glitter families, hiding information from parents, and portraying non-affirming parents as bigoted or unsafe. And you mentioned in your writing that the gender affirming care approach, which supports a patient's desire to change their body, really differs from standard clinical approaches, for instance, to something like anorexia. How did the profession of psychiatry stray so far from so many long accepted norms around treatment for dysphoria, as well as other core norms?
Yeah, I think that one of the things that really hurt the more analytic approach about this was you have a lot of, you had so many discriminations in the past in America, discriminations against people who are gay, race, belief system, all economic class. And then, it just seemed like logical progression is the next group of oppressed individuals that hasn't been really normalized is the people who are trans. And I think that is like, there was a lot of that is understandable. I mean, that's not where I think things went totally off the deep end. The problem is that it became this binary thing of you're either on the side of the oppressors or on the side of the oppressed. And I believe that this is one of the core things that led to this, kind of inability to have these honest conversations, because you didn't want to be on the side of the oppressors, just like, the people turning on the fire hoses in Birmingham. None of us growing up watching that wanted that. And none of us, who is bigoted. We want to stand up for the little guy. But I think what we didn't understand is that, when it's an immutable characteristic, such as your skin color, or, your natal biological sex, that's one thing where, that wholehearted, supportive attitude is awesome. But then when it comes to mutable characteristics, and somebody could, and people can just take on this identity so easily without really knowing what it is. And then all of a sudden you have all these people that, began to identify with this class that was historically victimized. And I think a lot of the clinicians felt this need to protect them. What they didn't realize is that there were a lot of consequences to them taking on this identity. Thinking you're trans and actually having real deep are two different things. And I think we were discouraged from trying to make that distinction between the two. Those who had an idea they might be the other gender, and those who had very deep seated gender identity issues.
Well, yeah, let me also chime in that this is all based on a paradigm of adults that have a fixed identity, that have a long standing, many years or decades of a feeling that they're uncomfortable with their biological sex. I mean, that's one population. But when you try to put that to kids who are still in the forming their, there is no evidence that we have any way that we can figure out which kid would go on to have a long lasting trans identity. And wouldn't we just let the kids grow up first? The other issue is, and I think Dave is correct that so you have to look at who goes into mental health care and who goes to be a psychiatrist among the physicians. We are people that tend to be very forgiving. We tend to be, we really want to warm fuzzy with our patients. We really want to be warm and supportive. And, that is great when you can have that with your patients. But we have trouble setting boundaries. We often overprescribe. Look how physicians started the opiate epidemic because we wanted to overprescribe for pain. Look at how we panicked with peanut allergy and recommended that everyone should, stay away from peanuts, and we made it worse for the kids. I mean, the medicine is really susceptible to over intervening and over treatment due to the psychological profile of the doctors, and other mental health professionals are also, in some ways susceptible to that. And I think about two paradigms. One paradigm is one end of it is stigma, and the other end is illness identity. And we've also been so vocal about trying to downplay any stigma that might be associated with anything, even things that are true mental illness that actually, are very impairing and problematic. And I think, yes, we don't want to give anyone who has, a severe persistent mental illness any more of a hard time because they have a very difficult life just because of their severe persistent mental illness. But when you start sort of taking away or saying that all stigma is bad and that's a problem, you open the door to illness identity. And right now, you should look at the last couple chapters in Anna Lemke's book, Drug Dealer MD. She's really good on this. And she talks about the adoption of illness identity as the breakdown of our society has caused it. And illness provides a way for kids and for adults to define themselves in this fragmented, difficult world. And the people with the illness identity are lionized as heroes. And so we have a bunch of perverse incentives that I think have played out in this trans debate with the youth that are pulled into it. And we need to be able to speak honestly about it. I think a lot of clinicians are not willing to, first off, criticize the field, and second off, not be that there are some limits to these anti-stigma campaigns. And part of what we've created is too many people associating with the illness identity, which is not going to be good for them.
And is that illness identity, is that recognized amongst clinicians? I mean, it does seem like that's obvious to most people who are witnessing what's happening, with younger people. Is that something that is talked about separate from, that seems like a much less contentious issue than how you treat gender distress.
Well, yeah. So it's really easy to talk about it when you have, non-epileptic seizures or, which are basically fake seizures, or what they call functional movement disorders, which is tics that you've acquired on TikTok. Dissociative identity disorder, easy to talk about it. People just don't want to talk about it with the issue of trans. So, in this case, no one wants to admit that this could be a pathological identity, because that would be then somehow totally different than all those other disorders. And I think we've boxed ourselves into that corner where clinicians know that this is often an illness identity, but they won't say anything about it.
Okay. I'm going to shift back and about these core norms, because one of the ones that was discarded in the medical field is we talked about the threat of suicide to justify prescribing blockers or hormones or to advocate for surgery, or allowing young patients to use that threat in order to get what they want. So even the way clinicians are talking about suicide, so it stems from external forces, single reasons, external forces like minority stress, or the idea that drugs and surgeries are all of a sudden suicide prevention, again, without evidence that that's the case. These things go against best practices for suicide care, right? Care of a patient who's suicidal ideation. They play on people's fears, and for both parents and clinicians, I think too, are obviously afraid that they're going to have a patient that's going to do something, to self-harm if they don't provide these treatments, if the patient believes it or claims it. But can you talk a little bit about that particular shift? This seems like a fairly serious one, because we're talking about suicidal ideation, and yet it's manipulative, not just from the clinician side, but also from the patient side.
Yeah, this one is obviously fraught and difficult, but I can tell you that I don't know what the answer is, but this actually can even go beyond trans. And I think that a lot of parents beyond the trans issue are worried about setting limits with their kids. They're worried about disappointing their kids. They're worried about, giving them a real sticking they're
David, your connection is not good, and we have lost you. Oh, we lost.
Oh, I'm sorry.
Yeah, we just lost pretty much everything. So go on back.
Okay. I don't know. Can you hear
Yeah,
me now?
yeah, yeah.
Okay. So yeah, the thing about the threat of suicide is it is, it's something that it is a very fraught topic, but it goes beyond the trans issue. And also sometimes parents are with non-trans kids are afraid of setting limits, afraid of giving consequences, afraid of taking away the cell phone or the video game because they're worried about, you know, who take their own life. Will I cause their suicide? And with the trans issue, it's obviously been amplified a lot. And one of the real problems with this, though, is when it becomes such a cultural given that, oh, if you stress out your kid, they might kill themselves. Well, suicide is a behavior that acts within that kind of permission structure of society. And if you're, again, planting this idea, predictable response to parents setting a limit, a predictable response to withholding gender affirming care is that you take your own life. Then it goes to the top of the menu of behaviors that a kid would think of behavioral responses that a kid might think of in response to this. So I think that in general, we need to have a talk about, as psychiatrists, there's a lot of kids that are being developmentally harmed by the fear of them, perhaps hurting themselves that really keeps us from setting the firm limits. And at the same time, we have created a culture where a lot of young people really do try to hurt themselves. So I think that one of the first things is like, yeah, to change how we're talking about it, change how we're kind of setting this expectation that one of the most common behavioral responses you might do is hurt yourself, because adolescents, as much as they say they like to go their own way, they really tend to be strongly influenced by the norms set by other adolescents. If you tell an adolescent that their behavior is extremely rare, for their age group, that actually, for a given situation, that's actually something that can motivate them to avoid that behavior. If you tell them that this is something all kids to change that presumption.
Uh-oh.
We're
Dave's
yeah,
breaking up a little. Let me
yeah.
also add something to this. So, one of the challenges that you always have with self-harm is that if you reward self-harm or threats of self-harm, you get more self-harm. And so all psychiatrists deal with this. Everyone trains and goes to the inpatient unit. The residents will often tell me, yeah, that patient was holding us hostage on this or that because of the, so that's the kind of, we know that some patients are threatening to harm themselves for tangible or intangible rewards. It is a reality. And I work in corrections, and so I see it there for sure. And the last thing we want is someone to hurt themselves. And we're really, we bend over backwards to try to stop that from happening. However, when we start accommodating and giving people, as I said, tangible or intangible rewards, like attention, like things they want, like not setting limits, we actually reward the threat of self-harm or the actual self-harming behavior. And when you reward something, you get more of it. And so we've gotten in a really, so it is true that this is not just about kids that are identifying as transgender, but in this population, it is an open secret that kids could use these, threats or the actual self-harm to then, get what they want. And so, yes, we've created really dysfunctional dynamics. We will, for whatever reason, have continually exceptionalized these kids and don't treat them in the way that we would treat other kids. And we've lowered or distorted our usual standards of how we address self-harm and suicide. And so I can't really explain why on everything it keeps being an exception in this one particular disorder. So we talk about it as a coercive family relationship. When you can see, when a child can see that you get upset about a certain behavior, they know how to then make you upset. And if making you upset can help them get what they want, then they will do that behavior. So once again, back to family dynamics, for this or for other things, this is also a tool that the child can use to exert power and control their environment and do stuff. So it's a complex situation. And obviously, at the end of the day, we want the minimum of self-harm, but that's obviously not what we're getting with our current approach.
And so clinicians, psychiatrists, other clinicians have, there must be ways of dealing with this with the general population of adolescents that do this coercive behaviors. So, and I imagine, there are techniques that do work with this population, or with the general population. Is there something exceptional about this group, or is it just that the messaging is so effective with them and with the clinicians that it is an exceptional case, not because there's something exceptional about the kids, but because of everybody else surrounding them?
Well,
I think these are the same kids that we've always been treating, and they're just presenting a different way. Um, and I once interviewed a priest in rural Sicily who was the exorcist for the Archdiocese of Monreale, and he talked about people who faked demonic possession. And I was like, my goodness, why on earth would someone fake demonic possession? And he kind of like went through the characteristics of, these young people not getting a lot of attention to their families, feeling insignificant. And I was like, oh, you mean the exact same group of people in the United States present with seizures? These are, the culture allows for different presentations of the same thing about where, okay, rural Sicily, you got a devil inside of you, uh, back in, 20th century America, oh, you've got a neurologic illness. And now I think it has sometimes come to, oh gosh, well, hey, I'm a different gender. And that's not all of the kids were saying. I'm not saying that's the explanation, but I do believe that it's kind of a way to kind of draw attention to the fact that, I feel insignificant, I feel unappreciated. And, you throw that in with all the stressors of being an adolescent and just how in our individualistic society, we all ironically don't feel special. You know, I think that's part of the setup.
yeah, let me add also, and this is not going to answer the suicide question as much, but if you look at the Edward Shorter work, like from paralysis to fatigue, which is basically a talk about where how psychiatry and culture have created different psychosomatic expressions of distress through the years in different societies. I mean, we don't get neurotic paralysis like they did in Victorian times. We now get other illnesses. And so over time, the culture codifies certain illnesses, and then the individuals in the culture express illness in a way to fit what is expected so they can get the attention or other things that come from adopting the illness identity. And the ecological niche is another author's sort of way to talk about it. And some mental illnesses have come and gone through the years. And so I think we have to talk about the interplay between culture and how we see things. And I think what happened in this case was that we have a long-standing data that adults who identify as transgender have a high rate of self-harm and even completed suicide. And unfortunately, that reality, it doesn't seem affected by what treatments they get, or if it is, not very much. And this is one of the problems. But somehow with that adult data exists, then all this got transferred into this new onset of children that really never existed before, and now are claiming a trans identity. And so why, I think we've discussed some of the reasons why, but I mean, why suicide in this group? I think it's because of the adult data related to self-harm in that population.
Well, let's go back just a little bit to talking about cultural influences. We've kind of already brushed up on this. Mental, physical illness can emerge for unknown reasons, for genetic reasons, can be the result of trauma, or as is the case with gender ideology, sort of manufactured through propaganda. David, you talked kind of maybe half seriously about writing a manual of cultural pathology to record these kinds of mental and physical illnesses that are more created through ideological movements, I think mostly fomented online right now. Can you talk a little bit about the differences and difficulties in both diagnosis and treatment when we're dealing with a social contagion?
Yeah, and what I was, and what I was focusing on is that it's not just that the culture we have in the psychiatric manual, the DSM-4/5, yeah, they have something called culture-bound syndromes. So they've always acknowledged there's some very strange syndromes that appear in certain cultures, like Watigo in Native Americans, where they have this belief that they're going to become a flesh-eating monster. And you have, many others that you can look up. And they're just basically ways that, a lot of the culture kind of gives you the kind of memes for which you build, your illness narrative. But and what I was talking about, a diagnostic manual of cultural pathology would be is a companion manual to the diagnostic manual of mental disorders. Is that culture is something that emerges when you have groups of humans that get together. Just like when you get a group of beavers together, they're going to start building dams. You get humans. Um, cultures have a function. Cultures have a function to promote the flourishing of the individuals within the group. They're this self-sustaining process, but that process can decay. Cultures aren't necessarily, it's like I don't think we talk about respecting all cultures and all that, but cultures can go bad. If you don't believe me, you can read about the Nazi Germany of 1933. You can see a culture gone very wrong. So when the culture stops building towards that flourishing, there's some things that are going wrong with it. I think that when you talk about the, kind of like the diagnosis of American culture and like one of the ways that we're going on, it is this kind of hyper individualism. We've moved beyond this kind of like, and this ability to choose your own, path in life, make your own prosperity and vote how you want to vote, speak how you want to speak. To now it's like, and you can define your own reality and expect that everyone else around you will accept it. You know, that level of individualism just isn't sustainable. You can't be so individualistic that you allow everyone to create your own reality. And I think for a lot of the issue is we've sold them on this illusion that yes, you're going to be able to choose your own identity. Everyone's going to respect it. You're going to be able to demand respect and conformity out of everyone. But there comes a time when these identities are going to collide. And that happens, when you have mixed gender locker rooms. That happens when you have, these groups of individuals. I think during sexual encounters, there's going to be the reality to define the reality that I think, externally exists. Um, and so this is one of the things that I think we believe that freedom extends to the point, that the individual can define reality, and that's one way that it's made it really, like, once you, like, if you take that as a premise, it's really hard to tell anybody that they're off base, that they're delusional. And I don't see this as being able to sustain itself much beyond the trans movement, because it's like after a while, I think people are going to get tired of it. And this is one of the areas where I really do worry about the kids who are being brought up with this trans expectation, is that there's going to become, maybe not everybody, but there's a lot of people who are kind of going to get tired of it. And there's going to be a lot of fatigue in trying to accommodate to all of these identities all the time. And I think setting them up with this expectation of everybody's going to follow along forever is not a good idea. Um, and so I think we have to understand that as modern Americans, as very advanced progressive people, as all of this, we are not perfect. Our culture has blind spots, just like every other culture. And I think we have to have the humility to understand that we don't have it all figured out. And I'd love it if our elites shared that humility.
Yeah, I agree with everything Dave was saying, and I'd also say that uh, if we looked at Joseph Heinrich's work about human cultural evolution, I'm not sure if the listeners know The Secret of Our Success or The Weirdest People in the World, but he coined the term weird, which is Western, educated, industrialized, rich, and democratic, and he talks about how human cultures, we are made to soak up culture because we're the only being that can only survive because we pay attention to what people around us are doing and we copy them and we see what works and we build on it. And these cultural adaptations have allowed us to be very successful all over the globe. But as Dave was just saying, cultures don't always progress, they can go wrong. And, over and over again, people have destroyed great environments through destroying their culture. Um, one of his in the Weirdest People in the World, he talks about how our group of individuals, which we think is normal, but as compared to other humans, is probably very exceptional. This Western rich, group was shaped by the marriage and family plan of the Catholic Church, and that got rid of cousin marriage and clanism and made us more idealistic, more analytical, less holistic. We value abstract ideas. We are less family based than we would be, and I would add, I think we should consider that whether that makes us more homophobic, or that we were more homophobic because of the outgrowth of the church, which drove same-sex attraction away from into the underground of culture. And so I think we can definitely come back and understand what's going on as a reaction as we're moving out of a phase of a more homophobic culture and sort of accepting some of the more diverse ways that sexuality plays out in our society and being more open about it. And that's maybe a good thing that is occurring, but we have a lot of this particular movement may also have a lot of bad things associated with it too. But so that's part of my analysis on how we got where we're at.
And I wonder, at a certain point, these interventions, gender, sex trait modification interventions, whatever, hormones and blockers and surgeries became available, and somehow word that these were available got out. How much of this do you think would have happened if there wasn't a medical pathway? Would we still, I mean, theoretically, this gender distress should be independent of a medical pathway, but of course we don't see that. So how much of this, is based on just the knowledge of availability of medical care?
Well, and it's not just the knowledge of the availability of it, which does drive the interest, but also the overselling of the results. I think there was this documentary that was made about these kids who gender transitioned in Netherlands, and it told this very quite incredibly one-sided story about everything started getting better. They stopped stealing. They stopped doing drugs. Everyone loved each other. They found perpetual Narnia, through their new gender. And produced a documentary before. I can tell you that if I wanted to, I could have made a really convincing one-sided deceptive work. It's the overselling of it also, I think, came from the clinicians who, when I first saw University of California, San Francisco professor, presenting on this, and she said, well, okay, we don't have any randomized control trials to show that this is successful, because politics won't allow us to have a randomized control trial. She's like, just kind of take our word for it, because this is too politically controversial to do a study on. So we haven't done it. And then we just very quickly swung over to, of course, gender affirming care works. You shouldn't do a randomized control trial on it, because those people in the placebo arm, they would be deprived of what we know to be life affirming care. So it was, it was the availability, and you can really do and I will say, you can do a pretty convincing job of transitioning a natal female to an adult male appearance. A lot harder to go the other way around, particularly after puberty's already been experienced. The original use of puberty blockers, like, people often talked about those as being better for mental health, but really the original suggestion of this, I think it was De Vries, in Netherlands, was, hey, if we do puberty blockers before males hit adolescence, they'll be better able to pass as adults when they transition to female. So yeah, the medicalization, the availability of it, and also the overselling and repackaging. Final, even though the cross-sex hormones and the puberty blockers are not FDA approved for those indications. If I was watching YouTube videos on trans, a few years ago, as I started to get more interested in the topic, and I noticed that there were a lot of advertisements popping up for puberty blockers. Even though the FDA hasn't approved this, so they shouldn't be advertising. But the drug companies knew to throw these ads in for puberty blockers in one videos. So yeah, it's, the capabilities are there. The overselling led to increased uptake, and the drug companies, they just saw cha-ching, there's a profit to be made, and I think they exploited it.
Well, yeah. Well, I'm sure they're happy with the results, because what is it supposed to be, a $4 billion industry now? Very successful.
Yeah, I think I should add, which goes right along with what Dave was saying, but the idea of placebo effect in these treatments has been woefully underexplored in the literature. Alison Clayton has a great article which nails all this stuff. I mean, you're giving these treatments that and telling people that you're going to get this amazing effect from it. And so you would think that the results would be amazing in terms of the anxiety and depression and all that stuff, just from the placebo effect and how pumped up all these treatments are. And so it's actually pretty damning that the treatments are not really showing that much of effect, even despite the placebo effect. We know that if you expectations have to do with how the outcome will be. And, but once again, in the short term, this also can drive. I mean, if you look at all the YouTube videos and what has been online that may be pulling some of these kids into transition, it's the availability of these younger people who have transitioned and are selling it. And they haven't been on it long enough to see what the long term, most of them, what the long term effects would be and the downsides of it all. And so I think once again, yes, the availability of something definitely changes how people see it, and the availability of these hormones and surgeries. I mean, obviously, we can do amazing things with those. It doesn't mean we should be doing those things, or at least not with the kids.
It seems like more and more, since I've been paying attention to this issue, there's been all these shifts. It started out as like born in the wrong body, and then that was like, okay, no, let's not say that anymore. It was, about this life, threatening condition, this life-saving medication, and it's shifting more and more to this idea of um, bodily autonomy, and that maybe evidence-based medicine doesn't matter. Maybe the evidence-based isn't important. Maybe the freedom to do what people want, even as adolescents, even as children, is the most important thing. I'm quite concerned about this shift towards the idea that it's more about autonomy. Are you seeing that kind of shift? Are you hearing that kind of shift from fellow clinicians?
Well, that is exactly what I was speaking of when I was talking about the rights paradigm and how,
Yeah.
many people just default to the rights-based argument because you don't really have to look at the evidence base, and you don't have to worry about the outcomes, and you don't have to worry about getting in a nuanced or complex discussion of whether this is an enduring trans identity or part of a contagion. And so I think definitely the rhetoric has moved in that direction. And because of a lot of the legal issues, I mean, this is, unfortunately, the reality is that the pro-transition side has an incredible legal workforce, which has been able to push things, down a certain road. So that is when the legal stuff is all flowing through rights, and courts are granting rights based on this. And so yes, we are left with that as being the new more recent paradigm of how people are talking.
Well, what does that mean for the medical field when it's not about, what's long term in the best interest of your patients, when it's being a provider of a menu of, you know, options they can pick and choose from depending on what they want the endpoint to be?
I'll go ahead and chime in again in that. Yeah, we trust in the medical field has been degrading over time, and then has degraded precipitously in the last few years. And I have a lot of concerns that the good things that we can do, and then in mental health care, the good things and important things that we do are going to be undermined by taking aside our usual thoughtful, nuanced practice and adopting this approach.
And and one of the things that has happened is also the way I've seen people talk about this. They're also talking about not just transitioning cross sex to the other gender, the other sex. They're talking about allowing your patients to switch between which male characteristics do you want, which female characteristics do you want, how about female breast tissue and a male beard and whatnot, and who's to say that's wrong? And I mean, this is the central problem here is really it's like they're pushing for transhumanism because when you're starting to say we're going to redesign human beings and create this new thing, you're no longer accepting the limits of what a human is. And I know that there's so many people who are doing this in different ways. Elon Musk with brain implants, whatnot. Um, but the end result of this actually is dehumanization. When you're trying to psyches aren't really made up for that. And there's a very, very controversial thinker, very provocative woman from England named Mary Harrington, who started to describe this new approach as like a meat Lego, that you think of the body as just with these parts that can be rearranged that have no, relationship to the whole. And, I mean, her term is harsh, but I actually think that this shows you is like what can happen when you start change the human body is you start to depart from what human is, and you start running into things that while they might sound good on paper, it's I am highly questionable of whether these are really going to gain long-term mainstream acceptance, or whether these people will be severely ostracized in the future once because what happens when trans is no longer the flavor of the month for political activism? What happens in between transition states when they've moved on to something else, when they've moved on to an economic issue or another thing? Are these people going to get the same support they're getting now? And I don't think so. And I think we need to be real about how long is the support that we're giving these people going to last?
Right, and what level of support will they need? Because I think it is a it's a huge unknown.
Yeah, this is like the equivalent of the Bush invasion of Iraq. Democracy, let's set it up. It sounds great on paper, but then to maintain this thing, it's going to be a Herculean task.
Yeah, concerning. Um, we have just a couple more questions, so we'll work our way through these, and then we'll take audience questions. In many states, the affirmation model is not only standard, it's law. So practitioners in mental health fields will need to take risks in order to bring the field back in alignment with the proven evidence-based approaches to mental health treatment. What advice do you have for clinicians in these states where the affirmation model is the standard?
This is a tough one because, I mean, I will just tell you honestly, I would have to move. There's no way. I'm from Minnesota, and there's no way I could practice in my home state right now. Luckily, I found myself in Texas due to some weird external circumstances. But if it became federal law that I would have to affirm every teen based on their identity, I would have to say, you know what? I can no longer see teens, And I mean, that is, I just like, I have a hard time standing in defiance of the law. But I think the other thing that is important is like for those clinicians, not everybody can pick up a move. Some people have like kids, mortgages, homes, and, social ties. All the clinicians, I think, need to band together about this and say, we're not monsters. We're just not going along with this. You know, this is a really, to say that we have to do this is an extreme, it's kind of like it's a violation of our own autonomy. It's a violation of what we see as our duty to not do harm. Really standing up for the Hippocratic Oath that we've taken and standing up for each other. And sometimes it, it involves a lot of courage because I know that I can face backlash. I mean, a lot of the people around me aren't supportive, but if I do think if all we do in our life is just kind of avoid the conflict, it may not change. So I do think that people in those states should band together. This is why we do not support this. Just make your voice heard and let the chips fall where they may.
Yeah, I mean, I would agree with Dave that I'm not going to participate in an unethical practice myself. So I think everyone, understands that they have to practice the way they feel is appropriate. I think most of those laws offer wiggle room regarding what exactly, they're sort of vaguely written. So I would consult exactly what the laws are, and I would find a good attorney. I'm sure that the lawsuits are coming in those states, and I would make sure that I'm helping move forward, a legal pushback against any restriction on practice that forces clinicians to do, shoddy and what I consider unethical care. That's in the short term. Many institutions and places are pushing people to do this type of care, and I don't have an easy answer to that.
Okay, well, I guess that was part of my question. My next question is, is the idea, I mean, yeah, Minnesota's pretty far gone. But is it possible, maybe one clinician on their own speaking up is going to lose their position or be tortured out of their position? If there was, in a clinic or in a medical system, if there was a coalition of clinicians who somehow found themselves and made a case for a more cautious, precautionary approach to these young people. Is that would that make a difference, or is it just so unacceptable to challenge this that
I bet that would be successful if people tried it, because I don't think that the establishment or those pushing gender affirming care can win on the subject matter, and they know it. And I think they would be sort of forced to back down if it rather than have a conflict. They would just prefer to intimidate and bully people into how they want to make it happen. But I think they know that they would lose in court, and that they don't have the facts behind them. But you would need a group of people to get together and say, no, we're just not doing this.
So we need a coalition. We need to form a coalition for wayward evidence-based clinicians so that they can find each other. Maybe we need a database set up for,
Yeah.
rational clinicians.
And I think we have established that that is probably the majority of clinicians, but at least from what you two have been saying, people quietly whispering their agreement, but being afraid to speak out. I think a coalition would provide some cover.
Yeah, I will say one thing though, and this is one of the things that's not good news, is that among the younger doctors, you're seeing a lot stronger ideology, but not in all of them. I find if I talk to them one on one, you've got to build up rapport and respect with somebody, with these younger doctors, show, hey, I'm on your side and I'm supportive of this, and I'm good at this as a doctor. I'm good at that, and and sometimes you can kind of nudge them towards at least accept the fact that I have a different opinion on this. But there's some of the younger doctors who are coming out really are trained as thinking, one of my biggest healthcare goals is advocacy, and to the point where they're learning more about is there's a risk they may learn more about advocacy than they learn about actually providing medical care. And so and this is one of the things within medical education is we need to balance that that need with the understanding of you also need to have collegiality and you need that commitment to the evidence base, it, beyond, because I think if we depart from evidence-based medicine, then really the door is open to everything. We there's no longer any quality control, and so I think we need to reaffirm within our education that we have to have respect for collegiality for the other clinicians, for discussing viewpoints, open debate, and yes, that there's got to be evidence behind the.
I would also say, though, that it is accurate that many medical schools, the educational capture of institutions is real, and that not at my medical school, but at many medical schools, the whole institution has been co-opted into the rights-based paradigm, and we don't really even need to think about any of the other things. We're just going to go with the rights-based paradigm, and this is all, and all the slogans are supported and believed and no one has questioned them. So you have a combination of groupthink and, sort of the confirmation bias and, educational. I mean, I agree with Dave that it's more likely that the younger physicians have been sort of brainwashed and really have not looked deeply at any of these things. I think any one of them, all they need to do is look deeply at it and they'll see it's a more complex, nuanced thing. They are all smart enough to get into medical school. They should be smart enough to figure that out. But it would, they don't want to look at it because the social costs in their micro environment is so high. And, it just is a reality. I know this is a Democrats for informed approach to gender. And so I would just say, the Democrats are the ones who can turn this around because primarily educational and medical school institutions are more democratically affiliated, and that if they just uphold like the old style liberal principles, we'll be fine. But if they become advocacy oriented, like Dave was saying, that's when we get ourselves in trouble. So I'm quite worried about the medical establishment.
Well, this goes back to a question that I skipped about, we talk about the cohort of young people who are being sort of brainwashed and indoctrinated, but there's this whole other cohort of people who are being brainwashed and indoctrinated. And that's, doctors, mental health professionals, teachers, journalists, institutions, just as you were, who continue to promote sex denialism and sex trait modification despite the lack of evidence. I guess sign of those very effective slogans. And what the way back from that is when we're talking about such a large population. I think about Mao's China, where citizens began to behave in very bizarre and irrational ways, turned against friends and family, were only focused on earning party approval. This has some similar echoes to me. So I think what you're saying about the institutions gives me pause also, because they're churning out more ideological doctors, clinicians, as you were saying. Maybe we'll wrap up with a couple questions for you, Chris. I know you're about to head off to Lisbon and do a presentation at the GenSpect conference. I'd love for you to talk a little bit about that, and also the project that you're involved in, the Restore Childhood Gender Toolkit. Will you talk a little bit about both of those?
Sure. I will quickly delve into my presentation, which I'm titling "When Perfect Storms Collide: The Ecological Origins of the Rapid Increase in Medicalization of Gender Dysphoria in Youth." And amazingly, in 2022, there was a paper called "Gender Affirming Treatment of Gender Dysphoria in Youth: A Perfect Storm Environment for the Placebo Effect, the Implications for Research and Clinical Practice." That was Alison Clayton paper I mentioned earlier. 4 months earlier, there was a paper, "The Perfect Storm: A Developmental Sociocultural Framework for the Role of Social Media in the Adolescent Girl's Body Image Concerns and Mental Health," by Sophia Chakas Bradley, which talks about how the internet causes more body distress, especially among girls, but also among boys, and how that has been a perfect storm, along with developmental issues, to make girls upset about their bodies. And so I think the combination of those two things have helped explain, how we got this large rise in gender distress in youth and medicalization of such. So that's my GenSpec presentation. And then I've been working with the Restore Childhood group on a gender toolkit, which is an excellent toolkit for anyone involved with schooling of any sort. We have it is a live document that goes through the evidence base about gender medicine. It goes through lots of the things that are being taught in schools today. It raises some fact-based and skeptical counterpoints, and also helps teach parents about their rights and how they can best navigate the fraught school environment these days. So both of those are things I'm excited about. The toolkit you can find at Restore Childhood website, where I think it's restorechildhood.com. I can't remember if it's the .org. And please download it and have a look, and we'd love to hear feedback on it. If there's anything that's not correct, or we did anything or we said anything that is non-factual in that toolkit, we will correct it, because we're really trying to make sure we appeal to and pertinent to this, spaces, that this is created by more people who are coming from a leftward political perspective, and it's very non-partisan, non-ideological, but it wants to address this issue of gender in a productive and positive way that we can move forward with.
Thank you. Both those things are exciting. I don't know if other people are going to be. I unfortunately won't be in Lisbon, but I'll be listening to the GenSpec conference, and I have checked out the toolkit, so that is available online. We'll post that in our on our in our Twitter thread about this afterwards. Make sure that people have access to it. We're going to move to questions, so please stick to the topic at hand, and please be brief. as always, we'll cut you off if you're not civil, although that hasn't been a problem for a while, thankfully. We've encountered problems trying to shift some listeners to speakers in order to ask questions, often if they're not on an iPhone. So if you're having trouble getting elevated to speaker, or it seems like we're not hearing you and you're not able to ask your question, please try logging out and then back in. Or you can post them and we'll do our best to uh, check those questions. Okay, we've got a couple people lined up. We'll talk to Letta Lestrange first, and then we'll talk to Fevers. Letta, you should be able to. Yep, go right ahead.
Okay, hi. I am a psych nurse. I primarily work on a youth inpatient unit, and I'm fortunate because the physicians that I work for, the psychiatrists have stopped referring to endocrinologists, and nobody has ever referred to a surgeon. I'm also in the Midwest, and I'm just kind of curious as to what shape this takes in something like an outpatient practice. Because we're inpatient, it allows us to punt a little bit on these things. And the whole issue with psychiatry and psychology as a whole is that it's patient self-reported. So for us, we can say, oh gosh, you can talk about that outpatient if it's something that you're serious about. And besides the fact that it makes me feel like I could never work outpatient, I'm just really curious as to the ethical predicament that it puts an outpatient clinician in.
Yeah, it's a good point because, for one thing is like, I'm never going to refuse care to anybody who comes in my clinic, even if I think they're going to be angry at my own beliefs. When it comes to a patient who's presenting with a trans identity, I don't, feel like it's always the first primary thing that you need to address with the patient. I'm going to provide them with information, honest appraisal of the evidence based, not really spun one way or the other. I'm going to inform them about biological practices. And I've had, and if a patient is going to get like puberty blockers or cross sex hormones, I am going to challenge a little bit. And I have had times there have been patients who've complained. I've gotten more complaints from the parents than I've of the kids than the actual kids who identify as trans themselves. Because I think for one thing, a lot of the parents take on this identity of I have to be the guardian of my kid's gender identity and I have to keep them away from this distress that might kill them. And they honestly believe this because clinicians have told it to them. And so, I definitely will also, there are times where I say, you know what, our primary thing we're going to work on right now is it's the depression. We're going to work on, substance use, whatever. And I think that a lot of times it's like if you can at least resolve the other, the psychological instability, then you put them in a place where somebody can at least do what we, call it kind of like gender exploratory work, which used to be kind of the norm is you would kind of explore the patient's feelings about gender and their experiences rather than actually just go with whatever cross sex identity they've taken on and just affirming and maximalizing that. But it's hard to find clinicians oftentimes who will be willing to do that gender exploratory approach. And I do think that when I'm making referrals, if I have somebody and I think that this is rapid onset gender dysphoria, it's like I have to be worried about, is the clinician I'm referring to them going to do harm by kind of emphasizing the wrong thing? And that's my perspective.
Yeah, one of the things that I'll add to what Dave said is that there's the group therapy first, which are a group of therapists that are committed to the idea that youth should have therapy before medicalization. And so that's a good referral if there's a clinician from that group in your community. And I feel like often in mental health care, we are faced with patient demands for things, and we have to provide care based on what we feel is right. And we can offer things. And if a patient doesn't want what we're offering, that's fine. It's a big world. They can go elsewhere. So we are trying to, do the best we can and help people. And if they are seeing things differently and want to go elsewhere, that is their prerogative. So I don't have a problem. I think it's a sort of my duty to be upfront with people. That being said, most of my work occurs, although I do see some patients directly, and in corrections, I see lots of them directly, but in outpatient, I'm mostly working with the residents and I'm trying to support them. Basically being honest, everyone's very nervous about talking to this patient population because it is so fraught.
Oh, sorry. And of course, I'm muted. So I'm talking here. Fevers is muted, and we're you should be able to speak. If you can't unmute, oh, there we go.
I think I can now. Hi,
Great.
hi.
Hi.
I had to drop down. I'm having problems with my connection. It's not you. Yeah, I'm fascinated by this discussion. I mean, I'm no expert whatsoever. I'm a social worker, and the last 30 years I've been working with kids with complex trauma backgrounds. So that's my area of expertise, really. But I've noticed a much larger percentage of my kids have had sort of become trans than in the normal population, and I'm quite interested in the comorbidities that go along with it, because for me it does seem that complex trauma, autism, certain personality disorders sort of go along with it. But what I wanted to ask you guys really was, again, it's only anecdotal, but I've been noticing online recently more stories and accounts from detransitioners, from young people who have obviously gone through the process, sometimes from a very young age, have been committed to that they want to change their gender, and have regretted it, and are now in a position where, and there's one girl that posts quite a lot, and she feels abandoned by medical care because nobody seems to be interested now that she's really wants to detransition. I don't know what the implications of that medically are. I mean, I'm sure that there are things that can't be undone, and there are things that you're going to just have to live with. But I wondered what you all felt about kids who get that bit older and actually want to detransition, and what the medical facilities are that are available for them. And we talk about therapy and medical services for transgender children, but and young people and older people, but what does that look like for people who regret it and who want to detransition?
That's a huge question. And honestly, I don't know of much that's available. I know that there are some clinicians who have started to work with these these individuals, but and I am actually, it's like where I'm at, in my clinic, I don't have the ability to craft my own practice exactly the way I want. But this is one of the things I have had an interest in, is learning more about how to deal with them. The thing is, from an evidence-based perspective, none of us had any idea what we're doing with the detransitioners. We don't have any evidence about it. And it's not because they don't exist. I love the ones who are outspoken, the Chloe Coles of the world, and there are others, because for every one of them, I feel like there's at least a dozen who aren't psychologically stable enough to come out. Be ridiculed, they're going to be criticized, just as Chloe has. And I don't 100% endorse everything Chloe has said, but I can tell you she's earned the right to say it. We do need to start coming up with some ideas, and this is one of the things that I've got a lot of other irons in the fire right now with my own clinic, but this is one of the things that I think I do feel like I need to suggest and help out in some ways, is us starting to get evidence-based practices for the detransitioners, because a lot of them are going to need access to care. They're going to need treatments that are developed. And, I don't think a lot of our solutions are political here, but I do think one of the things is the insurance companies who paid for the transitions, they should also pay for detransition care. If they were if they were automatically liable for that too, they might start thinking about who they authorize the transition on.
Well, and I'm sure, Dave, you know about, and I only know a little about it, but Griffin Severett, who died last month in July, and she was female to male, trans, and from what I understand, over some years, since she was very young, began that transition, and she had, I think, double mastectomy. Then she had phalloplasty, and had about 9 different operations in a number of weeks, because there was so many problems with her urethra and all the rest of it, and in the end, her body just shut down, and infection set in, and I think it shut some of her organs down. And from what I understand, she died of she had a second brain hemorrhage, and she was 24. And I was just, I personally think that maybe the beginning of the end of all of this is going to be the first big court cases where people who have gone through it, who have people have been pressured, but I remember that one of the things she said was she'd paid a few $1,000s on something or other because her insurance only covered her so far, but the operations that she had cost $500,000. And I just think, people are leaving themselves wide open in a way, because when people start to change their minds, young people, I'm 53, but when I was 15, there's quite a lot of things that I might have been absolutely committed to at the time. I'm going to change my mind in 10 years. So as those things start to happen, and they will, there are more and more people that I've seen online who are saying this was a massive mistake. I was vulnerable. I people were taking advantage. I just feel that there needs to be a real understanding and provision for people who come at the other end of this and need help and support, and I don't even know where you begin with it, because a lot of them have done things which are really kind of undoable. But these people, they're going to be more and more of them, I think, and we just need to be putting things in place for them.
Yeah, this is Dr. Kaliebe. I mean, I don't think there's any doubt that you're correctly identifying what's coming, and of course, we need to do everything we can to support everyone, not just the people who are happy with their transitions, but those who are not, and we owe them certainly the medical care they need. If we were willing to transition them, we should be willing to support them, detransitioning. And I think it's going to be, difficult for many. And, I don't know what, well, I guess we'll just have to see how it plays out. But that troubles all of us, I believe.
Okay, I think we are out of questions. If anybody wants to ask a question, do it now, and you do that by requesting down at the bottom. You'll see a little symbol there for asking. But otherwise, I think we'll go ahead and wrap up. We'd like to thank our guests, Drs. Chris Kaliebe and David Atkinson. To learn more about Restore Childhood's Gender Toolkit, go to www.restorechildhood.com. And again, we'll post that in the chat for this space. If you haven't already done so, please join Diag at di-ag.org/join us, join JOIN-us. Our power to reach our representatives is through our numbers. It's important to show that we are a silent majority who believe in classical liberal principles, following the science, ethical, evidence-based medicine for all, the power of civil discourse, protecting the rights of women and girls for sex-based spaces, honors and opportunities, LGBT rights, and the necessity of a compassionate, reality-based society where truth matters. Thank you for joining us, and have a good rest of your evening.
Thank you.
Thanks, everyone.